Okay, this will be pretty quick, actually. First off the bat, I want to make sure that you all use the following expressions. Time is testicle. You don't have to repeat it or nothing, just time is testicle. And castration by procrastination. Okay, those are important concepts. A couple of general things about testicular torsion, which is clearly the big player in this category of the acute scrotum. We're going to focus mostly on the kids, the pediatric population, where this is the biggest concern. The incidence of testicular torsion is 1 in 4,000 boys and men in their lifespan. The peak incidence is from 12 to 18 years of age. Just to review the pathophysiology of testicular torsion, people are predisposed to it. There are people that have, they're boys that don't have a firm tethering of their the tunica vaginalis to the back, to the posterior part of the scrotum, so that their testes are more susceptible to swing freely on the spermatic cord, on their vascular supply. And as you go through puberty, when the testis disproportionately becomes heavier, that's when you are most likely to have this problem where a heavy testis is swinging on this relatively smaller vascular supply. And so that's why it's puberty when the peak incidence of torsion is. Let's see. This is a bilateral abnormality. These are things that, these are review, but this is good to review a little bit at the beginning. These is a bilateral abnormality such that if it happens on one side, it's susceptible to happen on the other side. When a kid comes in, especially an adolescent comes in with an acute scrotum, a red, hot, tender, swollen scrotum, the differential diagnosis is the main things are torsion, epididymitis and orchitis, and the other big one is torsion of the appendix testis. This is something that kids get and not adults. And this tends to be the kids in the pre-adolescent group. For some reason, I seem to remember learning this many times as kids that are 5 years old or 6 years old. And I think I've seen a couple of cases in really young kids. And that's why, for me, I associate it with the really young kids. But the literature says that 10 years of age is the mean. So the mean for the actual torsion of the testis is in the around 14 years of age, whereas for the appendix of the testis is 10 years of age. And remember, that's the condition that's the more benign one, where it's just the appendix of the testis, which is just a tiny little structure that you don't need, which you can afford to necrose, sort of torses on itself, and it causes a lot of pain. And as that pain evolves and the swelling evolves, it can look, for all purposes, like a torsion of the testis itself. It can be very hard to distinguish when you've got a big, swollen, hot, tender scrotum. So this diagnosis of appendix torsion is the one where they say you can sometimes see the blue dot sign. You look through the testis and you can see a little blue shadow, and that's supposed to be the thing that you're supposed to circle on the exam question. But as we'll see, that's not all that reliable. There's some controversy as to how to manage a torsion of the appendix. And the reason why am I talking so much about torsion of the appendix is because that's actually the most common thing. And so in that age group, if you look at all the presentations of people that come in with something that's a really acute presentation of a tender, hot scrotum, that's actually the much more common thing. Torsion is only in about somewhere between 8 and 12% of those kids, whereas testicular appendage torsion can be in some series as high as 40% of those kids. So it's worth actually knowing a little bit about. And there's actually some controversy about how to manage it. If you really want to make that kid feel better and fix the problem, you take them to the OR and you can take that thing off and you cure the problem. If you don't, you can't, and it's acceptable to not do that, you can manage them conservatively and you can let them be in pain and give them pain medicine and anti-inflammatories, NSAIDs, for a couple of days, and then after 2 or 3 days it starts to settle down. But you got to hope that you were right and that it wasn't really a testis torsion and that it really was an appendix torsion. There's other things that can cause a torsion of that can cause an acute scrotum, tumors, trauma that for whatever reason you didn't know about. And ER docs, you always have to think about things like child abuse and things that the little boy might not want to tell us that are traumatic. He might have been assaulted or something like that. So that's important to keep in mind. Hernia, pyocele, cellulitis. Those are things that also are in this group. But the big ones really are epididymitis, orchitis, torsion, and appendix torsion. Those are the most important differential. I want to bring up another important clinical point, which sometimes we forget about, and occasionally someone gets nailed by this, and it's very upsetting, is when a young boy presents with abdominal pain and nausea and vomiting, always make sure to examine the testes, because it's one of those things. It's like the glaucoma thing and headache. You think to yourself, they always say in headache, always think about the differential diagnosis of glaucoma. And every time I read that or I'm speaking about that, I'm like, give me a break. Like someone actually came in for a headache and they didn't, the doctor didn't notice that there was a red, painful eye with a dilated pupil. But yet every year, these things come up in the malpractice literature as things that are missed. So once again, kid with abdominal pain and vomiting, nausea and vomiting, make sure you examine the testes and make sure you consider torsion because it keeps coming up. Okay, so let's talk a little bit about the abstracts in here. I'm not thrilled with the order, but we all have our own style of how we go through it. But I think it's better if we follow through the order here to avoid confusing folks. Abstracts 1 and 2 are both large case series. This is not science, and it's okay. It doesn't have to be. This doesn't have to be rigorous, randomized, controlled science. This is very helpful case series here because they show us counterexamples. They show us that all the things that we have been taught about the physical examination and also the imaging studies are fallible. So, for example, Pren sign, which is supposed to be something that's indicative of epididymitis. When you elevate the scrotum, when you elevate the hemiscrotum, they get relief. That's something that's supposed to be suggestive of epididymitis. Happens very often, for example, in torsion. So that's not reliable. The lie of the testis, right? We're taught that the lie of the testis becomes more elevated and horizontal in torsion. Helps sometimes, but it's not reliable either. And there are many cases of torsions where the lie is the standard vertical lie, at least in the opinion of the recording physician. One of the things that we just mentioned was the blue dot sign. If you see the little blue dot sign, it must be just the appendix that's torsed. And yet in that second paper, there were several cases where they saw and documented a blue dot sign and then went ahead to explore the scrotum and found out that in fact it was a torsion of the testis, not the appendix. So the blue dot sign is not pathodemonic by any stretch of the imagination. So kind of poking holes in these various signs that we've been taught. I think that probably everything I just said is something that is gospel to you guys. You all probably teach that yourselves to your juniors and to your colleagues. But the one I think that bears reminding is the cremasteric reflex, which I think a lot of us still think is pretty reliable, is not reliable. And you can see in both of those abstracts that there are several cases where there's a crossover, people that have cremasteric reflexes that are indeed intact, because they're said to disappear in torsion, that do go on to be found to have torsion, and vice versa. People that have absent cremasteric reflexes, and it just ends up being epididymitis. So in summary, none of the physical signs that we've learned about are reliable enough to rule out something that we consider a let's not miss this diagnosis. It's not like we want to miss this, and we'll get into why not in a minute. I think even more important than everything that we've just said is the fact that the imaging is fallible. And if you look in abstract 2, they did ultrasound in a subset of their patients of 26 cases. And in 3 of the 26 cases for whom ultrasound was performed with Doppler, the Doppler said the testis is okay, and it turned out that they had torsion. And I don't think that people, and I certainly didn't until I reviewed this literature, realized just how many times ultrasound actually will misdiagnose epididymitis when it's actually torsion. Abstracts 3 through 5 talk about the comparison between ultrasound and nuclear medicine for the diagnosis of torsion. And just to save you some time, they come up with test characteristics where the specificity is about 95% for torsion, and the sensitivity is about 80 to 90%. There's many, many papers on this. And for both of these modalities, the sensitivity is never better than about 90%. And so I think that's something just to sit and ponder for a second. You're going to miss cases if you rely on Doppler ultrasound. In terms of which test is better, let's just take a poll to see if this even needs to be discussed. How many people are still using nuclear medicine scintigraphy for torsion, and how many people are using Doppler ultrasound? Okay, so I didn't see a single hand for nuclear medicine, and so the reality is that it's disappearing. It's probably nearly equivalent in terms of its sensitivity, but one of the reasons that it's fallen by the wayside is because it's more operator dependent, and a lot of people, a lot of hospitals with limited resources can't afford to keep it up. It does take longer, and time is testicle, and so if it shows a positive for torsion, we would have wanted to know that sooner, and ultrasound is faster. And the other thing is that it doesn't show the alternate diagnoses as well. So if there's a pyocele or a hydrocele or a hernia, the nuclear medicine studies won't pick that up. So it's probably reasonable that ultrasound has replaced nuclear medicine. But I think the real issue here is because it's fallible, because ultrasound is fallible and it misses cases, is it appropriate to be using that as our primary triage in these cases? Okay, now, if anyone asks you on a test, an examination, what is the best thing to do when, what is the right course of action when a 13-year-old comes in with an acute painful hemiscrotum, and they maybe give you a couple of other things that are suggestive of torsion, what are you supposed to do? Call the urologist and get them to the operating room, right? And I wanted to just take a minute and maybe have a little discussion about a very important issue that faces us, okay? The payouts for missed testicular torsion and the necrosed testicle are high, and so the stakes are high in this game, and there is still no definitive literature answer on whether it's appropriate to take them all straight to the OR or whether it's appropriate to do ultrasound on these patients. And I want you to circle two articles. They're not particularly wonderful articles, but they're both very recent, very contemporary, and they represent either end of that spectrum of opinion. Abstract number 6, or no, not abstract number 6. Abstract number 5 is in the Journal of Pediatric Surgery. It's an Austrian study, and they are advocating scrotal ultrasound. Okay? You know, it's what we call a Mikey likes it paper. And what we mean by that is, this is what we did, seemed to work out pretty good for us. That's what we recommend that you do. It's not really a scientific paper, it's a description of how they roll at their place. They had 79 kids and they did scrotal ultrasounds, but there's a couple of things, and they say, listen, we didn't hear of any problems, but the fact of the matter is that a tenth of their patients they didn't have any follow-up on. It's possible that some of them went to Germany or another surrounding country or Switzerland and got their testis removed, their necrotic testis. I don't know, but you know, that's obviously a flaw with the paper. And the other thing that really bugs me about this paper is that the ultrasound Doppler examinations were done by specialist board-certified pediatric surgeons who were very experienced with it. So there's a big difference between, so they're doing the ultrasound, but they're also examining the patient at the same time. Well, there's a big difference between a pediatric surgeon doing a Doppler ultrasound and examining the testis, you know, after he or she is already experienced on examining a lot and taking them out and knowing exactly what's going on, and me doing it. So I'm very concerned about those two flaws in this paper as an advocation of doing ultrasound as a strategy first. And of course, it does take time, and time is testicle. And so if you really think that there's a torsion going on, how is it going to help that time if you delay it for someone else to come in and do it in an ultrasound? On the other end of the spectrum, we have abstracts. Just forget about abstract 6. Abstract 6 is talking about magnetic resonance imaging for torsion. Okay, I don't think probably any of you have any burning questions about that. I'm sure that you would be laughed out of your departments if you put in a requisition for rule out torsion on an MR. We're in the embryonic stages there, it looks like, so just forget about that for now. And even that paper is just talking about like subacute presentations. They've all had at least 2 days of pain, so forget about that. But let's move on to the other school of thinking, which is abstracts number 7 and 8, which is the we better explore all these immediately school of thinking. Okay, and that paper, Abstract 8, Murphy et al. In Pediatric Surgery International, also very recent, May of 2006. It's the same type of paper as the one advocating ultrasound. It's a Mikey likes it paper. There's no methods given in this paper. It's really just some sort of a retrospective chart review where they didn't even tell us if they had a standard way of reviewing the charts. But again, it gives you something for your dossier of the other point of view. So if now you've got a yin and a yang, you've got a paper that's sort of advocating either way, and there is no right answer. I can tell you there's certainly a lot of good arguments for having the urologist explore them right away, which is because such a high percentage of them are appendix torsions, and because that'll make the kid better and it will do some good, you know, between that and the ones that are torsions that you found right away and gave them an earlier chance of surviving, that's a pretty compelling argument for exploring them all immediately. The actual exploration is not like doing an exploratory laparotomy. I don't know if you guys know they can make this tiny centimeter incision. It's a real quick thing, can be done under local anesthesia. It doesn't need to, the kid doesn't have to be put down. The younger they are, I think the more likely you're going to have to put the kid down. But it's not a huge, hairy deal. But I mean, I'm sure that most of us in this room aren't going to be able to get their urologist to come in for these cases. And I'm in a teaching hospital, and even, you know, where all the, you know, there's doctors up the yin-yang, they're still not going to give me love, unless I, you know, if I say, look, I really think this is. But, you know, for most cases, they're not going to come down right away and take the patient to the OR. So let's have see if we can get some feedback on this issue. What is the situation in your facilities? Are you able to get a urologist to come right in when you think you got a torsion? Go ahead. Will your urologist make his or her way into the hospital in his or her Lexus when you make that call? So they come, they're right there. Okay. A deanologist. But what I think I hear you saying is that you've got a sort of two-tiered strategy or a Bayesian strategy. If they come in and you think that's what's going on, you're not screwing around. You're documenting on the chart, and this is sort of, I'm talking in a sort of didactic fashion here, you're documenting the chart. I'm calling urology. I called Dr. Smith at 16:02 hours. I think this is a torsion. I'm also ordering an ultrasound, but I'm calling Dr. Smith, and I'm telling him, I think you need to come in right away. And you're documenting that. But there's also kids for which you're like, I really don't think this is it. Maybe it's been going on for a long time. It just doesn't seem to be the right presentation. You're explaining why you don't think that's what it is, and at the same time you're ordering an ultrasound. So probably what you do is probably as reasonable approach as we can have. We can't be calling the urologist every single time we see a swollen scrotum. It'd be crying wolf too many times. But if we really think that's what it is, if we're scared, short time frame, very swollen, that's probably what we should be doing. Does anyone else have any wisdom to share about it? Yes, sir. Yeah, did you? Yeah, and it's a tough thing, and we all know this. I mean, just going, you know, stepping back. I mean, you know, it's very tough when the consultants don't actually come in and see the patients unless you're document. And then you worry about making. I've had cases like this myself where I'm worried that my documentation is too, for lack of a better word, asshole-ish, where I'm actually saying like. I told Dr. Smith that that's what I thought it was, and I don't want to, I'm not trying to attack or nail them, hedge them in and stuff. And so there's that fine line that you walk in the documentation. And there's no magic answer to it. But listen, we got to protect ourselves. We work in a high-risk environment, and as long as you're not saying anything, desultory or derogatory in the chart about the other doctor, I think it's reasonable to say, I think that's what it is. I'm very concerned about it. I called Dr. Smith. I told him that I'm very concerned that this be taken to the OR right away. I mean, there's only so much you can do. Yes?
A non-chart but legal place to put that documentation.
Incident report?
No, just the administrative duty, hey, this guy won't come in, whatever, no big deal.
Right.
If it came
Right.
Just go to those records, sure, that's what I was going to
Did everyone hear that? I mean, just other options in that situation is if you're really worried about a situation like that, you want to do everything you can do, you can call the chief of service, that kind of thing. It's tough, but anyway, I think that's very sound. The abstract number 9 by Jefferson is about manual detorsion, and I think sometimes we forget about this, is that, you know, the time is testicle, we've got a compromise in the blood supply, and so don't forget that in addition to calling the urologist and ordering the ultrasound, that you need to try a manual detorsion, because, you know, there's something that you can do to fix this problem right in your department. I'm not an expert at this. I've tried it several times, several of them unsuccessful, several of them I thought I was successful. What this Jefferson paper points out is that even when we think that the detorsion has been successful, were wrong a lot of the time, and 25% of the time when they actually went to exploration, they found that they were still at least partially torsed. Let me just talk about the technique for detorsing a testicle. It's something that I enjoy immensely. First thing is give them a lot of analgesia. Okay, just pretend it was your testicle or ovary, and give them a dose of a healthy, proper, appropriate, front-loaded. Don't nickel and dime them. Give them an appropriate dose of analgesia, morphine or Demerol or whatever it is that you're using. Then what you do is you open the book, right? So hang on. So you got to do this. You all know this. You go like that, right? Okay. And so you can either get one or two responses, right? You go like this, and you can get, right? Or you can get, right? So if you find that, and this is because only in apparently about 70% of the cases is this open book, this medial to lateral approach going to work. So if you find that it's making it worse, you're torting it more, right? Then you go the other way. So you try it first to see if you make it better, and if it's making it worse, then you can go medial to lateral, and you can try the opposite. Okay, so that's the detorsion process, or process, as I used to call it, for the Albertan. Okay, now there's a question, comment, complaint? Yes.
The state of the testicle is a dynamic process. You can detorse and torse, and so these studies that say, oh, it was this way by the time we get to the OR, it was that way. Well, in the between the two studies, it could have changed.
So I think that I think what you said reaches this. We have to mention this to everyone, because this is an important point. You know, it is and what you say is absolutely correct. It is a dynamic process. You can have torsion and detorsion, and that's sort of a segue into the next paper that we're going to discuss. It's a dynamic process. What was torted in the ultrasound suite may be untorted in the operating room, and that's absolutely correct. And that's one of the reasons that abstract 10 is so important. That paper by Lewis talks about the salvage rate for testes. It's from Cincinnati Children's Hospital. You know, I don't know what you guys were taught, but I was kind of taught 6 hours. And if you were taught 6 hours of pain means that the testicle is dead, that could be very dangerous teaching, because a lot of those are salvageable. And in fact, in the Lewis paper there, 90% of the testes were salvageable at 6 hours. 0% were salvageable at 2 days. But there seems to be a more important cutoff around the 12-hour rate. But the fact of the matter is it doesn't matter how long the thing has been torsed, and the history can be inaccurate. And they could have been torsing and detorsing. Some of the pain could have been coming at a point where they're already swollen, but it's actually detours. You don't know for sure. And in some ways, it's kind of analogous to stuttering angina or the stuttering pain of myocardial infarction. Diane was talking earlier today about why it might be dangerous to do a single troponin. And one of the studies that she didn't mention was one up at Vancouver General Hospital, or St. Paul's Hospital by Grant Innes, where they had people that said, I've had pain straight for 12 hours, but then yet when they measured their troponins and CKs, they only seemed to bump after 2 or 4 hours in the hospital, in the emergency department. And there's something that seems to prompt people actually coming to the emergency department. Maybe the pain got worse, that kind of thing. And I think the same thing is true of testicular torsion, that when they decided to come, something different might have happened. It might have been torsed completely, and before that it was only partial. Bottom line is that you don't know for sure on the basis of the history how long it's been torted, and you need to go ahead and pursue aggressively a workup on that patient. Don't delay, and go for it. And maybe you'll salvage a testicle even when it seems like it's been 18 hours. There's many cases that you still have salvage at 18 hours. Just coming down the home stretch, I want to talk just a wee bit about litigation. There's a little section there which I think is quite helpful, common themes in litigation, where they mention a couple of of things. In the Jefferson study, they had several misses. And they discussed that in their paper. What were the things that threw off the emergency physician? And I think that our pediatric emergency specialist here already alluded to that. Many of the cases you see happen on the soccer field, right? That's when the torsion happens. But what happens also is that physicians dismiss torsion as a possibility because there's a history of trauma. You all know that patients always will find an explanation for their symptoms, right? If there is no explanation, they'll find one. They'll make one up, or they'll create something that they think was the index. So often in torsion cases, the physician says it's a trauma, and they dismiss the possibility that it can be a torsion. That's a recurrent theme. Another recurrent theme is that the patient has white cells or bacteria in their urine. You can get those just like you can in appendicitis. You know, a lot of misdiagnoses of appendicitis are for people that have white cells in the urine, and they call it a UTI. But remember, you've got inflamed testis with surrounding inflamed other equipment and plumbing, and you can get white cells in your urine. Absolutely can get white cells and bacteria in urine, especially the longer that this torsion has been going on. That was another big pitfall. And then the third thing, it needs stressing, is inaccurate imaging studies that gave you the wrong answer. If you think it's a torsion, it doesn't matter so much what the ultrasound says, because your pretest probability is so high that they need to be explored. And don't forget that. So don't rely on imaging studies on cases where you have a moderate or high index of suspicion for torsion. That's an important point. Abstract number 11 is really not about torsion, but it's about lawsuits in pediatric emergency medicine, and it doesn't actually mention it in the abstract that you're there, but the fourth most common cause of lawsuits was testicular torsion. Number 1 was fractures and missing them. Number 2 is meningitis, missing it. Number 3 was appendicitis, and number 4, which is not listed there, you can write it in, was testicular torsion. So it's still a big player in the lawsuit arena. It still has big payouts of millions of dollars. Okay, and then I just want to finish by talking about why is it that if you lose a testis, and I actually happen myself to have 2 good friends that both have 1 testis and both have kids. Okay, why is it that there's such high payouts for testicular torsion? Well, it's actually a little bit fuzzy. The actual numbers or how badly injured these people are is actually is a little bit fuzzy. We do have evidence that shows that when you lose 1 testis, that there are antibodies that tend to attack the other testis. They actually talk about the blood-brain barrier being analogous to the blood-testis barrier. I think that for some people there may be some confusion about that. But anyway, there's some sort of blood-testis barrier. And there's also a similar situation when you lose an eye. You guys have heard about sympathetic blindness, right? And so it does seem that the rates of fertility are pretty substantial after losing a single testis. And the longer that you let it sit in there and necrose, and the inflammation to break down the barrier and the immune system to really work at this, probably the more likely you're going to have some sort of problem with dysfunctional sperm. And so infertility really is an issue. But Rick and I were just having a conversation about this beforehand, and he was saying, you know, in my opinion, if you have to prove damages in a tort, those people should have to wait till they are proven to be infertile. If they go on and have a couple of kids and life is okay for them, then why should they get a huge payout of millions of dollars? You haven't proven damages. But I guess the courts and the juries haven't really seen it that way. The only other possible reason I can think that it would be real damage to you to only have 1 testis is if maybe you were a testis model or something. But even for that, you could get a prosthetic put in. So anyway, the issue is infertility, just to remind ourselves, and it does appear to be a real phenomena. And whether it's legitimate or not, the juries continue to give big awards for this problem. So anyway, that's all I got. Okay, go ahead.
Small question.
Yeah.
If you have a very long transport time, is there any immediate things that you can be doing to reduce the likelihood?
That's an excellent question, and I'll just repeat it. If you have a very long transport time, is there anything you can do to mitigate the possibility of longer time for? And I think that depending on the comfort level of the provider, if you're for example, a nurse practitioner involved in transport, or if you're a physician, for sure you should try to detors. You should give analgesia in the field and try to detors. But I think to tell our paramedics that would probably be a little bit pushing it. You're talking about like a 3 or 4 hour transport time, that type of thing, right?
Sometimes longer than
Yeah, or longer than that, yeah. So I don't know what to tell you. I mean, I worked in northern Canada where we would often have situations like that, and often it was nurse practitioners that I was dealing with, and I would have absolutely no problem saying to them, hey, what does it look like? Does it look like one is going higher? And I would actually walk them through a detorsion procedure over the phone. I think that's a very reasonable thing to do. I don't think anyone would have any problem with that, so I would suggest that. Putting ice on it, those types of things might help with the swelling, but it's not going to restore circulation to the testis, so I don't think that'll work. Short of detorsion, I don't think there's anything you can do to mitigate that. Like, the sort of testicular hypothermia, right? I don't know. I don't think that's actually interesting, though. Yeah? Local nerve block for torsion. You know what? I think that you can do that, but I guess that would be a pudendal block. And I've done them in obstetrics. I learned how to do that when I was delivering babies, but I don't know how that would be done on a guy. That's something to. In terms of local infiltration, I doubt it, because remember, the pain is being generated from structures that have come to the scrotum. These are gubernacular structures, right? They're coming, right? So this would be something that, yeah, it would have to be, a more proximal block. Okay, and the last things, I'm not going to talk about in great detail. The last things in this was regarding epididymitis. There's a little ditty on epididymitis. I think you all know and have seen lots of cases of it. That's one of your big differential diagnoses. The main things to know in those papers are that there doesn't seem to be any real proof for this heavy lifting related epididymitis. That's one of the points that one of those abstracts makes. And the other important thing for you to remember is, even though we keep being taught in medical school that the young kids get don't get chlamydia and gonococcus, they do. Even the very young preteens are getting these infections, and they act as if people don't get STDs after the age of 40, and we all know that's not true either. Last shift I was on, I had a grandma who was positive for coke in her urine. She was like 82. So, I mean, that kind of thinking is kind of outdated. You must consider the full spectrum of diagnoses in that. In all of the age groups, and STDs happen at all age groups. That's important to remember. And then the only other point there to make is the CDC has changed the guidelines for gonococcus. In case you haven't been seeing and treating a lot of it, depends where you practice, you can't use fluoroquinolones anymore. There's too much resistance, and so they've changed the guidelines, and Dr. Hendy gives the current guidelines there, and the website, which I think we should all be using regularly to keep abreast of changes. So I want to finish there. Thanks very much.